basically a rheumatological emergency, and you must exclude it in any patient that comes to you presenting with a painful, swollen, red joint, because it does have quite drastic consequences if this wasn't to be treated adequately. So it's basically a pathogenic inoculation of microorganisms into a joint, and like I said before, it can actually lead to irreversible joint damage if it's not treated. So in terms of the risk factors, it's usually good to take a good history to determine if this patient is most likely to be at risk of this. So anyone that's got a history of prosthetic joints, that's also a good point. Any existing joint diseases, and anything that will suppress the immune system, whether it's medications that they're taking, whether it's chronic conditions, and also intravenous drug users as well, because that also provides a port of entry of pathogens into the bloodstream. And again, the elderly and young children as well. So in terms of what can cause it, again, the most common is the hematogenous spread. So typically from things like abscesses, dental infections, skin wounds and things like that. And other ones can be, again, like penetrating trauma and infections of the actual bone as well, can be part of it. And again, joint aspiration surgeries, so all major things have an iatrogenic cause as well. So causative organisms, typically it's Staph aureus that causes septic arthritis, followed by streptococci. In the younger generation, so adolescents and young adults, we're typically thinking, could it be a sexually transmitted sort of bacterium such as Neisseria gonorrhoeae? Also for the immunosuppressed patients, you want to think about your Pseudomonas and E. coli, and other gram-negative bacilli as well. So does anybody want to maybe pop into the chat, how would you actually expect a septic arthritis to present? Or if you want to say out loud. Yeah, basically. Yeah, excellent. Yeah, so it can be systemic as well. So you typically get in fever, tachycardia, them generally being unwell. The actual joint would be very red, swollen, very, very painful. Usually if it's lower limbs, typically the hip, mainly in children, knee, I think in adults, they will be struggling to sort of weight bear as well. So these are the good things to kind of pick out with your questions. So like I said, yeah, the knee majority of the time, and the hip, again, it can be upper limb as well, but it's particularly lower limb in both peds and in adults as well. So look for erythema, any swelling, severe joint pain, any effusion, reduced weight range of movement, and the inability to weight bear as well. And they'll have systemic symptoms. Also, another thing to be aware of is the fact that typically it's only one joint that's presented. So if you've got an isolated joint that's obviously quite swollen, then you really do need to think, could it be this? So investigations, so we need to take your blood. So your full blood count, you'd expect your white cell count to be raised. And again, your inflammatory markers such as your CRP and ESR to be raised as well. Urate, I think it's kind of good to investigate that, as you'll see later on when we talk about gout, and lactate would be raised in this as well. Blood cultures, because you want to kind of rule out sort of septicemia. And what we need to do with this is aspirate the joint. This may require ultrasound guidance, and we want to send it through to cell count. So we're looking at the white cell, any gram stain to identify any bacteria. We want to look for culture and sensitivity. So this will be a good idea. So if there was bacteria or any pathogens present, it will enable us to choose the correct treatment and antibiotics to treat this. And crystal examination is also good, again, for, like I'll talk a bit about it later, with gout and pseudogout. You can consider an x-ray of the joint, but typically joint aspiration is your absolute go-to when it comes to septic arthritis. There's this criteria as well, which will basically make you think this is one of your top differentials. I know we've mentioned a few of them before, such as having fever, not being able to weight bear, and having a raised white cell count and inflammatory markers. So just got a question. I don't know if you want to put the poll up. We got it. Yeah. Just bear with me 1 second. Okay, so which one of the following is expected on joint aspiration for septic arthritis? So do you guys want to have a little quick look at that and let me know what you think? Can I just give it another minute? Okay, I think most of you answered now. Oh, getting a few more. Okay, great guys. So most of you have kind of selected C, and a couple of you have actually selected B as well. So we'll just go through this. So the reason why it would C is the correct answer is because one, that's the only one that's positive for gram stains, and your white cell count is typically pretty high. It's over 50,000 cells per cubic millimeters, and majority of those white cells will be neutrophils. I can see some of you have put B as an answer as well. So it does have blood in it. So this is like blood in the joint opposed to septic arthritis. Another thing that doesn't make it to be septic arthritis is the fact that you've got a negative gram stain. You'd expect it to be positive in septic arthritis, and also your white cell count is also pretty low as well. But I've got a few more questions kind of introducing a bit of joint aspiration pictures, so we can discuss that in a bit more detail later. So well done everyone. In terms of managing septic arthritis, this patient clearly needs analgesia, so ibuprofen, paracetamol. You need to drain the joint, so basically decompress it and give antibiotics. Now typically, say if you're in an OSCE situation and they ask you how to manage it and what antibiotics to choose, you would typically follow local policy. But because the most common pathogen is Staph aureus, we give flucloxacillin, and it is recommended for about 6 to 12 weeks. So it is a long-term treatment as well. Sometimes you might have it might be difficult to aspirate the joint. You do need to get rid of all the septic material, so you do need to sometimes take them to surgery and actually wash it out as well, but that just depends on the severity of the septic arthritis. Okay, so moving on, we'll start with gout. So this is very common, a lot more common, one of the most common hot joint conditions that actually presents in primary care. So it's basically deposition of the monosodium urate crystals in the synovium of the joint. So it's typically associated with chronic hyperuricemia. So this is basically either you're having so much uric acid being produced, or you having a reduced excretion of it. So typically look on the history whether patients are taking any sort of diuretics, such as thiazide diuretics, if they've got any chronic kidney disease or anything that may reduce the excretion of uric acid. Increased production might be typically like a cancer patient that's receiving chemotherapy, and that in itself will cause a release of uric acid into the bloodstream as well. So also the typical patient will typically be obese, consume quite a lot of alcohol, might eat red meat, seafood, etc., and they'll have like cardiovascular risk factors, typically hypertension and diabetes, in their history as well. So in terms of the clinical presentation, it can present quite similarly to septic arthritis, but what makes gout more distinctive and the features to particularly look out for is that you do have symptom-free episodes and you have acute flares that occur, they come and go. So these can develop into maximum intensity in about 12 hours. And like septic arthritis, you get a hot, painful, swollen joint, quite erythematous as well. Typically, the first presentation is the metatarsophalangeal joint, so of the big toe, and that's affected in most presentations as well. You can also get tophi, which are basically these depositions of urate crystals in soft tissues, which can occur around the joint as well. Sometimes these can actually be noticeable on X-ray as well. So does anybody know what can trigger an acute attack of gout? Oh, I just saw someone just mention about the Cocker's criteria. Yeah, that is for adults. Some medications, yeah, dehydration, binge drinking, eating meats, yeah. Okay, great guys. So the one thing to look at is if there's a sudden rise or fall in urate levels. So you wouldn't want to suddenly give a patient with acute gout a medication that's going to suddenly change their urate levels, even if it's going to lower it. Someone said, binge drinking can cause it as well, and high protein intake. So again, eating things like red meats and things like that. Trauma and surgery to the joint can also trigger attacks of gout as well, or anything that can destroy cells and release urate into the bloodstream, so any destruction of DNA. So we're talking like chemotherapy and radiotherapy. So that's kind of associated with tumor lysis syndrome. And again, reduce urate clearance. If they've got like an AKI on top of a CKD or something like that, they're always at risk of changing in urate levels. So we'll want to investigate that. Again, the investigations for all of these are pretty much the same, because your main thing you want to do is rule out septic arthritis. So again, joint aspiration, and you want to look at the synovial fluid. So you'd want to do a gram staining, look at the white cell count, look for culture and sensitivities, and you want to investigate for sort of crystals as well. So these will be negatively birefringent needle-shaped crystals. So I'll show you here. So as you can see, they're needle shaped, and if they're in the direction of light, they are yellow, and if they're 90 degrees towards the light, then they are blue. So that's what it basically means, and that's pretty much a feature you should definitely look out for, especially on your questions, because that will differentiate between gout and pseudogout and everything else, and not just the presence of crystals as well. On the X-ray, you'd expect joint effusion. So you can see around here on the hallux here, you've got complete sclerotic margins and complete erosion of this joint here, and you can see it's a lot more swollen than the other joints. So that's indicating this joint effusion. Okay. So second question. So I just need to get the poll up, won't be a second. Niraj, have you got the poll?
Yep, sorry.
Okay, brilliant. So yeah, what's the first line management of an acute flare of gout? Okay, good guys, yeah. So most of you put D, which is correct. Some of these other treatments are also used in gout, but not for particularly acute flares of gout. So for acute attacks, you want to do conservative management first. So that's typically ice packs, resting the joint, elevating the joint. Nice guidance say to give NSAIDs or colchicine, and also gastroprotection if you're going to administer them. Sometimes if the first line treatments are contraindicated or not suitable for whatever reason, you can give oral steroids such as prednisolone, and also intra-articular steroid injections is also another option. In terms of prevention, again, you want to always go conservative first before you do pharmacological and then surgical. So lifestyle interventions, you want to advise a good healthy lifestyle, weight loss and avoiding alcohol intake, reducing alcohol intake and avoiding foods high in sort of like purines. You want to introduce urate lowering therapies. Now, one thing that's really important to consider is the fact that you do not want to introduce them within an acute attack, because it might precipitate another further acute attack due to the changes in urate levels. Like I said before, any sudden increase or decrease in urate levels can actually precipitate an attack. So that's what you don't want to do. So you typically leave it about 2 weeks after an attack, when all the symptoms have subsided. So the first line is allopurinol, and that's a type of xanthine oxidase inhibitor, which helps to lower urate levels as well. So moving on to pseudogout. So this is similar to gout, although you get deposition of calcium pyrophosphate dehydrate crystals in the synovium instead of urate crystals. So this is more common in older patients, and again, similar presentation to gout, although your larger joints are more affected. So the more proximal ones, typically the shoulder and the knee. Again, same investigations. You want to do your full blood count, using these, your inflammatory markers, urate levels, lactate is also good if you're thinking septic arthritis, and joint aspiration. So same investigations you want to do with the joint fluid. However, with this, you will get crystals, but you get weakly positive bifringent or brick/rhomboid shaped crystals. So when we looked at gout, when it was polarized to light, with a light direction, it was yellow. Now it's gone blue. So it's kind of like the opposite. And also there are a lot thicker brick cuboid shaped crystals, which will be found in the synovium as well. Okay. So you can x-ray the joint and you get cartilage calcification. That's also another characteristic feature of pseudogout. So I don't know if you can see the arrow there, but you can see the joint space of the knee, and there's slight opacities within that joint space, and that's just starting to calcify, and that's quite characteristic of pseudogout. And management is similar to acute gout. So you want to give NSAIDs to reduce inflammation and help with the pain. And again, you can introduce sort of steroids orally first, so such as prednisolone, and then you might want to consider intra-articular steroid injections if the other things are contraindicated or don't help. Okay, so moving on to reactive arthritis. So this is one of the HLA-B27 associated seronegative spondyloarthropathies. So this is basically a list you should probably know of the HLA-B27 spondyloarthropathies, including ankylosing spondylitis, typically in young men. That's kind of the classic picture. Psoriatic arthritis, which we'll discuss in a bit. People with inflammatory bowel disease also can have arthritis associated with this, and obviously reactive arthritis as well. So they're typically in younger patients, so 20 to 40 years, and it can develop following an infection, so which is around 4 weeks. However, no organisms can actually be found within the joint. It's a sterile type of inflammatory arthritis. Okay. So symptoms can last for around 6 months, and they're typically caused by dysenteric illnesses. So a patient with a history of food poisoning. So the most common pathogens are Salmonella and Campylobacter. And also with younger patients, you also want to consider about sexually transmitted infections, most commonly chlamydia. So does anybody else know how reactive arthritis may present? Oh, someone just said seronegative. Oh, seronegative, basically, when you test for your rheumatoid, I think it's rheumatoid antigens, they're basically negative. That's what it means. I'll go over it in the investigations bit. So reactive arthritis, yeah. So like Reiter syndrome, yeah. So yeah, the famous saying, can't pee, can't see, can't climb a tree. So that basically can't pee, we're having uveitis, can't see, uveitis, and can't climb a tree, so pain in the joints. So yes, we have pain in the joints. So it's typically an asymmetrical oligoarthritis affecting around 2 to 4 joints, typically in the lower extremity. So painful, swollen, and redness. You'll have conjunctivitis and anterior uveitis as well. All the bits that are associated with reactive arthritis, and actually other HLA B27 spondyloarthropathies, are dactylitis, so inflammation of an entire digit. You can also get systemic symptoms, and you can also get inflammation at sites where tendons actually insert bones. So you might have Achilles tendonitis and plantar fasciitis, and these usually present in a patient that might have swollen joints, typically a young male, and they'll present with heel pain as well, because that's quite a common fascia to actually be affected in reactive arthritis. So investigations, so we're going to do our usual bloods, and if we're thinking it could potentially be septic arthritis, we'd want to do sort of like the lactate and stuff. But with reactive arthritis, you usually do have more than one joint affected. So going back to sort of the seronegative comment, so when you do sort of your rheumatoid arthritis antibodies and you kind of look for them in the blood, they will be negative in reactive arthritis and any of this whole group of spondyloarthropathies. You could also do genetic testing for HLA-B27, and again, joint aspiration. Management is symptomatic treatment versus long-term management as well. So symptomatic treatment, you want to think about analgesia and maybe something that will reduce the inflammation going on. So that's why NSAIDs are quite popular. And long-term management, we look for DMARDs such as methotrexate and sulfasalazine. I think there's quite a few to choose from, but I think those are the most ones most common ones that are used. Okay, so psoriatic arthritis. Again, it's another one of the HLA-B27 associated seronegative spondyloarthropathies. So 15% of patients with psoriasis will develop arthropathy, so not everyone will. And there's different types of it. So you've got one that presents very much like rheumatoid arthritis. So that's kind of why it's also important to test for those antibodies as well. You have asymmetrical oligoarthritis, sacroiliitis, that basically presents with like lower back pain. And the worst type is the bottom one, is arthritis multiplicans, which basically completely deforms your hands. You have like pretty much most of your joints in the hands are completely deformed. Your fingers are kind of not aligned correctly either. So that's the most severe version of it. So clinical presentation, a lot of patients have psoriatic lesions, so they're like thick scaly plaques, and they can actually develop before the arthropathy or maybe even after. You'll have nail involvement, which is also quite a distinctive feature, so onculitis and pitting. And like I kind of said before, you get with these HLA-B27 conditions, you do get sort of dactylitis, synovitis, enthesitis. I don't know if I'm pronouncing that correctly. Again, presenting with things like heel pain. So investigations, again, bloods, rheumatoid factor and anti-CCP will be negative, hence why it's seronegative. Genetic testing, you can have joint aspiration if you think septic arthritis is a differential, but again, multiple joints might actually be affected in this. And x-ray of the joint, and they say it's like a pencil in cup deformity. So as you can see on here, this is like a normal finger phalanx, and this one is got this pencil in cup. I don't really know, I can't really see the pencil in cup, it's just more round. Your proximal phalange is quite round, like that, and you can see it here on this x-ray where it's kind of rounded here off like that. So that's also a kind of feature of psoriatic arthritis. Okay. So does anybody know how we'd manage it? Yeah, DMARDs. Yeah, brilliant. Yeah, fantastic, guys. So we break the management up into sort of acute management. So if they're having like flares, and you typically want analgesia and things to reduce the inflammation. So we've got NSAIDs and corticosteroids for that. But then we also want long-term therapy, and long-term therapy that plays a huge role are DMARDs. Physiotherapy can also be involved as well, and biologics, so monoclonal antibody treatments can also be introduced, but they're not typically first line. So your first line for long-term treatment are your DMARDs. So key points with a hot joint, we're basically, all these are the differential diagnoses of it, and these are the things you want to kind of consider every time someone presents with a hot, swollen, erythematous joint, very painful. And it's just all about kind of picking out those distinctive features of each one to kind of think what's the most likely diagnosis. I mean, we've covered them. Trauma is always going to be an option. You might expect with trauma a lot of bleeding as well, and same with hemarthrosis is pretty much the same thing. So it's so important to kind of look at the history. Does the patient have any bleeding disorders or any clotting abnormalities because of the trauma and DIC? So it's important to look at that. So again, important investigations. I would literally just do this for pretty much any hot joint you come across, just to be on the safe side, because you literally, first thing you want to do, your priority is rule out septic arthritis, because that's the most dangerous one. And again, all you want to do is prevent irreversible joint damage and prevent the patient being from really systemically unwell as well. So again, start very simple with the examination and the history, so taking the vital signs as well, the observations, think bloods, and then go for more invasive procedures such as sort of your joint aspiration and imaging if necessary. So ultrasound can be used. It's usually used to help aspirate the joint if it's more difficult, and x-rays can also be used to see sort of the damage that's been actually done to the joint and if there's any erosion and bone changes. Okay, I think we've got some questions now. Okay, so question 3. I've got a 63-year-old male with a background of hypertension, which is controlled on bromflumetazide, has CKD stage 3, type 2 diabetes mellitus, and presents for the first time with an acutely painful, swollen left first metatarsophalangeal joint. He's able to wait there. So those are his observations. So from the following, what is more likely to be expected on joint aspiration? I think one of you've answered already. Just give it a few more seconds. Okay, great, guys. Most of you have selected B. So yeah, no, that is correct. So we need to think about what's the important parts of the question. So we've got this patient's on a thiazide diuretic. As we know, thiazide diuretics can reduce the excretion of uric acid. And also the age of the patient is also quite relevant as well, because gout can present in a similar age, and the past medical history, so several comorbidities as well. And also he's got CKD stage 3, which may also affect urate secretion as well. And typically the first metatarsophalangeal joint is affected, so that should be a big hint towards gout. Observations, I mean, he's hypertensive, he's tachycardic, but tachycardia may be due to the fact that he's in pain. Temperature is normal, which is also reassuring. So when we're looking at the answers here, we get positive for negatively bifringent, the needle-shaped crystals. So the needle-shaped ones that are the ones that occur in gout. Other parts of this question, you've got the yellow coloured and high white cell count. That's also an inflammatory picture as well. So I think some people put A. Again, not far off. Pretty much again an inflammatory type picture. However, the actual types of crystals you get with A are for pseudogout. So C is basically blood in the joint, and D is basically the normal picture of what your joint aspiration should look like. So low levels of white cells, colourless, and again negative for crystals. Okay, so question 4. A 35-year-old male presents with a painful, stiff and swollen left knee and heel pain. His temperature's 36.8, heart rate 110, and obviously his BP's there. And now he's recently had to take time off work due to gastroenteritis, and he has a past medical history of atopic eczema. What is the most likely diagnosis? So just give a couple more seconds. Okay, so a little bit more of a difficult one. So the answer for this one is reactive arthritis. Now, I know a few of you put psoriatic arthritis. So the main thing to look at is, again, the age of the patient, but I guess you can get that with A, so fair enough. Heel pain as well, like with all HLA B27 ones, you can get heel pain. So that can also be psoriatic arthritis. But the main big clue here is the gastroenteritis. So usually reactive arthritis can occur due to a dysenteric illness, so Shigella, Campylobacter, and things like that, or a sexually transmitted disease such as chlamydia. So he's recently had gastroenteritis, so it's more likely to be reactive arthritis. I've also put the atopic eczema in there, a bit of a skin condition to kind of throw people off a little bit, but that's nothing to do with psoriasis. So that's why reactive arthritis is the correct answer for this case. But yeah, but well done everyone. That wasn't like too easy, that one. So yeah, so the age group, plantar fasciitis and the dysenteric illness. So question 5, a 50-year-old male, a 50-year-old male presents in A&E with a right swollen knee that is very painful. He admits to using IV drugs. On examination, he's unable to weight bear. His knee is swollen, red and tender, and those are his observations. What's the most likely diagnosis? So a nice easy one for you guys that I hope you can get. And I have noticed some questions in the chat, which I'll go over. Okay, just end the poll. Yeah, so well done everyone. It is septic arthritis. Because you look at the main ones are unable to weight bear and the temperature. He's got a fever, and obviously his IV drugs are a major risk factor because that's pathogenic route into the bloodstream. Unable to weight bear is quite common in people with septic arthritis. Not everyone with septic arthritis will necessarily have a fever either, so you should have a low threshold to investigate this. I'll answer the questions at the end if that's all right with everyone, because we've got one more question to do. So question 6, I think this is the last question. A 61-year-old female presents with several swollen and tender joints in her right hand. On examination, her proximal interphalangeal joints in her 2nd to 4th digits are swollen, red and tender. She has evidence of nail pitting and oncholysis. She has also been having trouble with several red scaly plaques on her lower limbs. What's the most appropriate long-term management for this condition? Okay, yeah, great, guys. So when we're looking through the actual question, this patient's got like a rheumatoid kind of picture to psoriatic arthritis. So we've got specific nail changes such as pitting, and we've got a hint towards psoriasis itself with the red scaly plaques. So the most appropriate long-term management is DMARDs. So A here is for long-term management for gout. C is also appropriate, but that's more for an acute management, and TNF inhibitors are also appropriate for this condition. However, it's not the first thing that you would go for.